Why don't we, if we begin, people will come. If we build it, they will come. So, Dr. Fink, can I ask you to come up to the table in front? I hope everybody enjoyed the lunch and entertainment. We're very fortunate to have Dr. Sheri Fink with us as a keynote speaker today. Dr. Fink is a correspondent with the New York Times and has written some really important books, I believe, one of which is 5 Days at Memorial: Life and Death in a Storm-Ravaged Hospital. After Hurricane Katrina, Senator Susan Collins and I, I always forget whether I was chairman and she was ranking member, or she was chairman and I was ranking, because we were pretty close, and all that changed was the title. But oh, the golden bygone days. But we did an investigation of the federal government response to Hurricane Katrina, which obviously was much less than it should have been. And one of the striking things to me, and I've been thinking about it during our work on this Biodefense Commission, was the inability of the public health system to respond to this crisis. And it does have direct connection to the demands on our public health system, should there be, God forbid, a bioterrorist attack or a infectious disease pandemic. So that your work on this is of real relevance to us. We're very grateful you're here, and we look forward to hearing from you now. Yeah, press the button, and when the green light goes on, you're on.
Green, that makes sense.
Okay.
I see those links as well. So Memorial Medical Center was a vibrant community hospital in New Orleans leading up to 2005. And then it was surrounded by floodwaters after the levees failed in New Orleans, drowning one of America's most beloved cities. The heat rose. Like in many hospitals, the backup generator system could not run the air conditioning, even when the backup generators were functioning. And that is a common problem I've since discovered, and there are no regulations requiring that to be addressed. The hospital also was not protected against flooding, like in many American hospitals in flood zones. Again, regulations don't require them to be. So the leaders of this hospital knew that within hours, all power would likely fail as the waters rose. Rescue helicopters began arriving at Memorial, but they could take 1 or 2 patients at a time. There were around 250 patients and 2,000 people in this hospital complex: doctors, nurses, staff, and family members. So I ask you just for a moment to cast your mind into that scenario. Of course, none of us can imagine it without being there, but trying to is a useful exercise. If you were in some position of leadership, how would you make a decision like which patients would get on those helicopters first? So would you think about, could it be the sickest patients because they rely on machines like ventilators to breathe for them? Could it be the healthiest patients because you could move them quickly and you might have a better chance of saving people who could survive? Their conditions could worsen if they waited for a long time. There were babies in the neonatal intensive care unit. They were fragile, but if they made it, they would have a whole life ahead of them. So would you want to factor in age into this sort of ethically weighted decision? Or what about older people who might have poor prognoses, but who had so much wisdom, who had taken care of others throughout their lives? So what would society be like without our elders? And then there were the medical professionals themselves and the health professionals. They were frightened, they were tired. Some of them had chronic conditions, were older. And of course, their work would be so needed after the disaster in terms of that long recovery phase that we now know from repeated disasters is really the most important one. So should some of them be put on those early helicopters and gotten out? Katrina was extreme, but it wasn't unique. And similar triage scenarios, as you pointed out, arise whenever medical infrastructure crumbles or when a surge of patients could cause the needs to outmatch the resources. So some other examples, just to step back from Katrina for a moment. We've anticipated this problem in future disasters, including infectious scenarios. There's been some federal funding for planning around which patients would and would not get access to hospitals in case of a large pandemic, such as the 1918 flu we heard talked about at lunchtime. There wouldn't be enough ventilators or critical care beds to go around. That's actually rationing, the R word that nobody likes to use. Just the other week, a meeting was held at the Institute of Medicine, now called National Academy of Medicine, looking at rationing that is already occurring around the shortages of prescription medications that is, plaguing the US. And that would be particularly worrisome if a biological agent caused a large surge of patients. So another example that we had recently was the Ebola epidemic that was really the one that was out of control in 2014 and 2015. And I spent about 3 months in West Africa reporting on that and observed some of the moral distress that healthcare professionals faced when they had to make some decisions. I think we often think about, well, if we don't have the right countermeasures, at least we're going to keep everybody comfortable. And what we forget is that keeping people comfortable requires a lot of resources too. And during the Ebola outbreak, that was pretty much without an effective vaccine at that time, without effective treatments. The health providers that we all saw the pictures of in their suits going into these Ebola treatment units, really all they could provide, the resources they were providing, was comfort. And they had to ration that because they could only stay in those suits for so long. And there was not a lot of good technology, and there still isn't in this Ebola outbreak that we're seeing now, to allow care providers to be in more comfortable yet protective outfits or uniforms. So these are some of the examples of why Katrina, when it forced these ethically tinged and value tinged decision-making processes, these things come up over and over again in different scenarios. Even when doctors from this country went to work in the Ebola outbreak in 2014 and 2015, one of the things, another example was that there were special treatment units set up in case these caregivers who were coming across the world and risking their lives might get sick. And they had a higher level of care. There were some point-of-care diagnostics, and they had rudimentary air conditioning systems that were not available in most of the Ebola treatment units. And then it quickly became a question of, well, who should get access to this? Should it be only the foreign workers? Well, at least the Americans, for example, could be helicoptered and flown out. They had that chance, and they did if they got sick. What about the local caregivers? Could you really set up an Ebola treatment unit for just for foreigners on Liberian soil and not offer it to Liberian healthcare workers who got sick? So you can see just so many examples of where these kinds of questions of triage and rationing come up. So going back to the Hurricane Katrina example, when the helicopters started to arrive, it's also a question of who makes the decision, who gets to choose, who gets access to those critical resources. So in this case, because the healthcare providers hadn't thought about this in advance, they hadn't practiced for it, so they just made an ad hoc decision and they made their best possible choices. It was mostly doctors, sort of take charge individuals who got together and came up with a triage protocol. And so they got some of the sickest patients out first, intensive care unit patients. Those of you who were rooting for the babies, they chose to get them out first. But they also chose at that moment a group of patients who would go last. They taped pieces of paper with numbers to patient gowns. Ones were the relatively healthy, twos were the moderately sick, and the threes were the terribly ill or patients with so-called do not resuscitate orders. And the threes would go last. And I asked some of the care providers why they chose this. And they said, well, I figured somebody who had a do not resuscitate order didn't want extraordinary measures used to sustain their lives. And so I decided they wouldn't want to be saved at the expense of others. Another one said, well, I figured somebody with a do not resuscitate order had probably, not much life left, and therefore, the quote, the least to lose compared with other people. But of course, perhaps there was a wedding that person wanted to get to, or perhaps there were other reasons why the value of their life, had an important weight to their families. And of course, and for what it's worth, and again, the physicians made their best possible choices, but again, the former Institute of Medicine did convene an expert panel around this question and said, it's hard enough to get people to sign end-of-life preferences and do not resuscitate orders to begin with, so therefore using them as do not rescue sort of triage protocols isn't a wise thing to do going forward. What happened was that after this initial group of patients got out, in fact, the power did fail. Gunshots went off outside the hospital, rumors circulated of violence and danger, helicopters came less frequently, and the rescue efforts lagged. Pets were not allowed to accompany their owners, and doctors began to euthanize them. Pets, by the way, were in the hospital as part of getting the staff to feel that they could come. Yes, okay. Ooh, that one's strong. So in fact, a whole day passed, and the desperately sick patients grew even sicker. Some of them began to die, and it was thought that others might not make it. So what should be done about them when it was time for everyone else to leave? A question arose: what about putting the patients out of their misery? So this actually began to be discussed in this hospital, in this modern American hospital in 2005. Ultimately, it was found that around 20 patients were injected with morphine and a powerful sedative and died. And they were not only patients who were teetering on the edge of life. One was a 61-year-old doting grandfather who was partially paralyzed. He weighed nearly 400 pounds. Elevators no longer worked, and he was on the 7th floor, and staff who I interviewed said they felt that he might be just too heavy for them to carry to the helipad and to rescue at that point. And I think this is just, for that level of desperation to inflict people who work in a hospital that quickly, after a day without power is very alarming. And I think it's, we sometimes underestimate just when we are such a technologically advanced society, when that is withdrawn from us, how vulnerable and desperate people can become. So sometimes our greatest strength can become our weakness in situations like this. That particular man, Emmett Everett, had fed himself breakfast that morning and asked the staff, "Are we ready to rock and roll?" So he'd expressed the desire to be rescued. He told his nurse, "Don't let them leave me behind, Cindy. Don't let them leave me behind." So the book that I wrote, 5 Days at Memorial, is about what happens when disaster strikes and the places and systems our lives depend on fail at the moment we need them the most. I myself am a physician by training, and I've worked in disasters and conflict zones. My first book was about a war hospital under siege for 3 years in Bosnia during a genocide that Senator Lieberman and others worked so hard to try to prevent. But never outside the realm of movies had I heard of conditions getting so bad that doctors and nurses felt their only option was to hasten patients' deaths. There were others in this hospital who disagreed and refused to participate. And so I set about trying to learn more in the hopes of that understanding this might help us in future disaster scenarios and emergencies like the ones that you're committed to trying to mitigate and prevent here. One of the questions of why this happened had to do with the hospital's disaster plans. And I just want to point this out as one of many factors, but it was very interesting because we talked about, this came up earlier, that by 2005, actually more than $1 billion had been made available to the nation's roughly 5,000 hospitals to promote bioterrorism preparedness. And so the hospital's bioterrorism plan in 2005 ran 101 pages. It had 11 pages devoted to hurricanes, which are quite a likely scenario in New Orleans. So I don't think that, I'm not recommending here that that investment in bioterrorism preparedness should not have been made. In fact, it's quite the opposite. It's just the need to recognize that these investments that we make, some can make us more broadly protected and resilient, and others we need to think kind of about specifics for specific scenarios that may be likely in different areas. And another thing is just that one-time investments aren't enough, and I think we've heard this over and over, but it's really true. A preparedness posture requires this kind of exercising all the time. It's just like you wouldn't show up on game day if you hadn't practiced, and that's really what preparedness is all about, at least what I've observed over the years. And so in some ways, much has changed since Katrina. So the federal government, through the Centers for Medicare and Medicaid Services, has instituted, as of last year, at least basic disaster planning requirements for healthcare providers of all sorts. And that was a need recognized very soon after Katrina, and it took like 12 years to make that happen. But along the way, as that proposed rule became a final rule, some of the more stringent preparedness requirements slowly were taken out as unfunded mandates, particularly a set of requirements around generators, backup power, which we've seen even last year with Hurricane Irma, so important for example, nursing homes to have. There was a dozen patients who died in one nursing home that just lost its air conditioning system. And the heat rose. So, you know, I think that the measure of success of this particular new legislation will really depend on how it's enforced, how it's interpreted, and that would be one of my sort of suggestions in terms of recommendations, is really looking at that and how that can be made useful, because we have had for years people dying in healthcare settings, in emergencies. And so challenges remain. Our infrastructure is vulnerable. There's a public disengagement and unpreparedness. Is very hard, I think, for humans to look at worst case scenarios without having actually facing them, sort of in anticipation. It seems to be a problem we all have. There's also this funding perception that you can sort of shoot money at something right after something happens, and this was discussed earlier, without realizing the need to sustain those investments. And there are more and more people in the community with medical needs. I won't get into this, but we're talking right at this moment about institutions, but I just had published a piece in the Times Magazine about a month ago looking at Houston and Harris County after Hurricane Harvey last year, and just the problems with reaching people and prioritizing people who have medical needs in the context of a mass emergency. And that in some ways is an even greater challenge when people are outside of institutions and you need a whole systems of preparedness. And we've got 911 systems that are problematic and very patchy around the country. EMS systems, the same thing. Very little federal sort of standards and very little federal funding support to improve that critical pieces of infrastructure around healthcare that will be so important in the case of a bioterrorism episode or pandemic. But I've learned in every case that there are actions that can make a difference, that can help us prepare better, help our health providers as well as patients in such dire scenarios have better outcomes. And so one would be to look at infrastructure and ways to solidify it, whether by stronger building codes, mandatory retrofits, which are incredibly expensive and always after a disaster seem to be the one piece of legislation that doesn't get through. But is there a way to improve public support for even private institutions that may have thin profit margins but need to make some of these investments in being better prepared, because they serve all of us. They're serving this critical role. I've already spoken about preparedness to be seen as a perpetual task. And also, finally, I would just like to say that there's this issue of trust. As we all know, if there should be a bioterrorism incident, if there should be a pandemic, how the public does, how many people die, will largely depend on the level of trust that they have in the people who are putting out messages about how to protect themselves. And I think that there has long been a sense amongst public officials, hospitals, you name it, that these institutions that really want to maintain trust, that they feel they can do that by pulling back on communications, by tightly controlling communications. And I think that sometimes that can be counterproductive, because then people start to fear, they start to come up with their own theories. And so whatever can be done to improve trust is going to be so, so important, especially at this time where there's so many people who don't trust critical institutions. So I encourage you to, of course, I'm biased as a reporter now, but to engage with the public, even on vulnerabilities, on these questions of how to sort of ration or make difficult choices around who gets resources, so that the public will be prepared and be able to engage and not just freak out. And then finally, I think so much more needs to be done. You know, there has been this investment in some of these crisis standards of care, rationing protocols, but what we really need investments in are ways to maintain standards, not lower them, to try to prevent these horrific, impossible choices from having to be made. I mean, that should be the real goal. So I'll end there and take your questions.
That was excellent. Thank you very, very much, because you portrayed the at least two aspects of this, which is the capacity of the system to respond in health or medical terms, and then the other dimension, which we haven't really talked about hardly at all, is the inevitable moral judgments you have to make if you have demands on the health system that go beyond the capacity of the system. So how do you ration, the R word? And it's very thought-provoking and important for us to think about. So you spoke to this somewhat, but I want to just sort of ask you the direct question, and acknowledging that for reasons that we need not go into, Katrina was an unusually powerful storm, and the vulnerability of the dikes and all the rest in New Orleans. But and of course we're seeing a lot of extreme weather now. So in another Katrina-like event, or less extreme, are you confident that we've done some things since 2005 to prepare our public health system to help more people than the Memorial Hospital was able to help?
It's really a mixed bag. It's so, I think that for one thing, there's a lot more awareness of the issues, and certainly in the healthcare field, there's more awareness of the importance of these questions. And certainly now with this new CMS rule, there's some accountability for health providers around this, but it's still a bit wishy-washy, and there's just so much infrastructure vulnerability. You know, I mean, even around when we think about when we had the Ebola outbreak in West Africa, there was a system set up to try to make sure we had hospitals that were prepared to handle people with very dangerous pathogens, you know, suspected of being infected. But sometimes, you know, these are sort of sit around and aren't dusted off. And so to the extent that they can be that there can be more attention and more focus and incentives for using those facilities for practicing in between the actual disasters, that is really important. But no, I mean, I've continued to report on disasters throughout, and while there are some improvements, we saw, for example, in Puerto Rico, many people dying because, likely because of the vulnerabilities of the healthcare system when we lack, you know, running water and electricity and so on.
One more question. We get accustomed around here to PhDs, but we don't have too many MD PhDs before us. So and that's your case. So to ask you to go both to your experience that you've talked about as a correspondent, but also as a doctor, what are the different kinds of demands that an infectious disease pandemic would put on our public health system than, for instance, the hurricane did in New Orleans?
A lot of things. And first of all, I just want to address one thing from your previous question where you mentioned values in preparing for these infectious pandemics. I want to say specifically that there are some good resources around how to have the public involved in that very difficult conversation, and that has been done. It's been sort of, I think we are afraid of, oh, the public will react so badly to this, but in a few places where there's been an effort to have fora and get sort of public input, experts have been impressed both at the sort of ability of the public to discuss these things and also that there are concepts that come in that you wouldn't have thought about if you hadn't asked the question. So just putting that aside, but a few things that if there were an infectious pandemic, which there could be at any time, we know the flu virus could mutate and we could face this. So it's everything from you know, primarily shortages, critical care shortages, saline solution, which is already in shortage, partly due to the hurricane last year in Puerto Rico. So there will be a lot of focus around that and a lot of problems around that. Also, as countermeasures become available, of course, we do have efforts to create vaccines and whatnot, and we saw this with H1N1, a little flavor of it, that as that vaccine became available, there was a lot of tension in society about who should get it first. So that needs to be thought about. And then nobody wanted it later. And so again, public trust, those issues, very critical. Those are some that just come to mind.
Very helpful. Thank you, Dr. Fink. Governor?
Thank you, Doctor. Your experience at Memorial gives us an insight that very few of those who have participated before the panel been able to share with us, so we appreciate it. I just want to change the circumstances a little bit. You were concerned about the evacuation of a hospital that was going to lose its capacity to serve and to heal. So that's one complication. Let's say you were at Memorial Hospital, notwithstanding the natural disaster, but there was an Ebola outbreak at the same time, and you had to deal with it with multiple patients. Are there lessons learned with regard to the hospital's preparation for Katrina that could be applied to a bio event that you could share with us, and particularly if you didn't have a countermeasure, medical countermeasure for it?
Thanks. Well, I just had this sudden vision of trying to evacuate a hospital with Ebola patients in the middle of a storm. And it reminded me of one thing that we saw during the Ebola outbreak, which is that there are very few sort of transportation resources for people who have these types of scary infectious diseases. And that's something to look at, whether it's ambulances or air transport in particular has been a big issue. And it's a very limited availability, biohazard, protected resources. Also, I remember in New York City, public health officials talking about when they had the one case of the doctor who had come back from West Africa and got sick in New York, and even just trying to find a company that would go and clean the apartment. You know, and you can think of all the contractors that New York City has to do cleanups, and I think it came down like they could barely find one that would do that job. So this is all why it's really, really important to practice these scenarios and work through them ahead of time, because you come up with things you would never anticipate until you either really practice with a very realistic scenario or have it happen in some way. So in terms of what's been learned and how, you know, I think we actually saw that. We had a few cases in American hospitals that caused a lot of problems. For example, in Texas, two healthcare providers caught Ebola in an American hospital from a patient. So we realized that we don't necessarily have a lot of preparedness around how to, you know, protect our healthcare providers. So we have, you know, great health infrastructure here, but that was a big lesson that we learned, the need to invest more in that. And I think it's still, you know, now that that outbreak ended, the attention really went away from that. And people who I speak with who work in hospitals don't necessarily feel that they're more prepared. So I think just in general, keeping an eye on those and having drills and having experts being, you know, weigh in on that.
Lessons learned during your response to Katrina that have been applied now at hospitals, hopefully not just in New Orleans, elsewhere. What changes were affected because of your experience?
So in New Orleans, a lot of things changed. There were investments made, particularly for, you could look at just Memorial Hospital itself, but this was more broadly, where the hospital is reopened under a different name, but they dug their own well, so they'll have a supply of water during a disaster. They, you know, raised the electrical system and protected it against flooding. Right. And the sad thing is that we see those kinds of improvements made in places that have had a disaster, but we see far less of that in places that haven't had a disaster. And I remember interviewing the preparedness expert for what was then JCO, it's now Joint Commission, which is a big hospital accreditation provider, one of the main ones in the US. And they, shortly before 9/11, had started to come up with some standards that they wanted hospitals to follow for emergency preparedness and bioterrorism preparedness. And after doing this for years, this official told me that this horrible conclusion, which was that he felt that the places that were most prepared for disasters, the hospitals, were the ones who had gone through them before. And not only ones who had gone through a disaster before, but ones who had gone through the same disaster before. That's not acceptable. How can we broaden these lessons? And it really comes down, we haven't talked about this, but it's about resources, it's about money, and it's about political will. And if that doesn't exist, we can have all the lessons in the world, and we can know what we need to do, but we won't implement it. And they're fair questions for policymakers and for people who run businesses, how much to invest in rare but foreseeable and potentially catastrophic events. And that only knowing the stakes and the consequences of not preparing can we make decisions as a society and as policymakers about that. It's another form of triage.
Had the hospital ever red celled or played a what-if scenario with staff and local emergency planners? What if such and such happens? How do we respond? There's a lot of conceptual, there's a lot of tabletops with that. Had they done it before in your experience with hospitals generally? Did they ever, after Katrina, did they plan out these scenarios?
I think that one of the main requirements of this new CMS rule is for 2 drills a year. But in terms of how realistic they have to be and whether the CMS will actually, you know, enforce that to some great degree and look at that, that's a big question. I don't think right now we're there.
Thank you. Thank you. Thank you.
Thank you, Governor. Senator Daschle, Ken, do you have questions?
Dr. Fink, thank you very much for your presentation and your answers. The one word that I'd come back to that you've mentioned now very effectively more than once is trust. And I must say, as I think about scenarios, one of the things that I don't think we've given nearly enough attention to or priority to is the degree of misinformation that is possible as a result of an incident, especially if it's a biological incident of some kind. We saw a glimpse of that with Ebola, but with the extraordinarily orchestrated attacks on the media going on daily, with cybersecurity issues now being well documented, and the combination of those two factors along with social media, I think we have an extraordinary challenge in trying to discern truth from fiction and stay away from hyperbole and misstatement of fact. What advice, if any, would you have for the panel on inoculation and preparation? What could we do to inoculate and prepare more effectively for that plausible concoction of misinformation and the disaster it could cause?
It's very well said, and it is very concerning. Everything from one of the reasons that experts believed that Ebola got so out of control in West Africa was in part because these were, in some cases, post-war societies, parts of countries where people didn't trust in government, didn't trust health institutions, and this was part of the mix in terms of trying to get people to change, like the key important, changing what they did to protect themselves. And so that would, and we were not immune from that. There was, as you pointed out, a lot of misinformation here in the US. We had, one of the public health leaders have extraordinary powers, for example, to limit civil liberties, to quarantine people. And in some cases, I interviewed health officials who did quarantine people coming back from West Africa, felt that it wasn't scientifically necessary, but they needed to do it to address fears of the public. And that, again, can backfire if you aren't basing your actions on science. It's such a tricky mix. Social media is both a threat to good knowledge, but also an opportunity. It allows certainly, communication with the public that had previously perhaps been mediated. So now experts, for example, and public institutions can use social media to get important messages out. But again, you need that baseline of trust. There has been some research that you could look at in terms of the role of the media and public information and the level of public fear and proper versus improper understanding around Ebola. That has been looked at. And it was interesting because I used to go around saying, information is the antidote to fear, to use your analogy. I thought as somebody who went to West Africa for 3 months and reported a ton of stories for the Times, I thought that was going to help tamp down fear. But in fact, some of the research suggests that sort of illogical fears went up, not just purely based on the volume of coverage that we were giving these topics. So this is something really worth looking at. And I think you've hit on something that could be very constructive going forward, looking at how to take some of those lessons and really prepare well around that sort of issue of public trust and communications.
Thanks, Tom. Ken, do you have a question?
Just if I may, a quick follow-on to Senator Dassel's. Thanks for your presentation. So you mentioned trust, you mentioned transparency, disclosure to the public, and you mentioned one thing that intrigued me. You said there should be, I don't want to put words in your mouth, but more upfront discussion from the government about vulnerabilities. And needless to say, part of our mission here is to remind people that we are vulnerable and we need to act. But in terms of how that builds trust, what are you alluding to? It almost as though you're thinking back to a particular incident where we might have engendered more public trust if we'd been more forthcoming about the vulnerabilities before those vulnerabilities became manifest. Am I right?
Yeah, I mean, I can think of it as an individual, as a reporter. Whenever a public official refuses to answer a question, I have a sense that I shouldn't trust them, and that not just a public official, but anybody really, you know. And I think the public can feel the same way, that, you know, what are they hiding? And so maybe being open about vulnerabilities is a way to both engender trust and also help the public understand why you want to make certain investments, why you think the nation should have particular programs that have been discussed today. So it's, I don't have any science behind it. It's just more of, I guess, a logical thing, gut thing.
Thanks. You know, we started late, and you've been so interesting, we're even later now than how we started. So I'm afraid we have to end it here, but thank you very much. I hope we can keep in touch with you. Your experience and your ideas are very valuable to